Hello dear students, welcome back to my YouTube channel Physiology Learning. Today we are continuing with the ECG series. In the previous video we have discussed the axis calculation which helped us to locate the heart and try to identify which ventricle is getting hypertrophied. In this video we are going to discuss the most important topic of all of ECG, that is the ECG changes in myocardial infarction. So let's get into the topic. So first things first, this is one of the most important topic. Why? Because the acute changes of myocardial infarction can be picked up in an ECG and immediate treatment of the patient can be done, and it could be a life-saving procedure also. So that's why we have to understand what are the ECG changes in myocardial infarction. Most of you know that how the pathophysiology of myocardial infarction happens. That is why there is a blood supply which is compromised and it is leading on to the ischemia of the tissue, which in turn is causing the irreversible damage and the death of the tissues. These things we are not going to discuss in the video. We are going to focus on what is the ECG changes. So a myocardial infarction based on the ECG changes it can be divided into STEMI and NSTEMI, non-STEMI. STEMI means it is the ST segment elevated MI, that is the myocardial infarction. Most of you know that it is the ST segment elevation in a myocardial infarction. But there is another group of MI which is also called as non-ST segment elevated MI. We are going to discuss a little bit about the non-ST segment elevated MI also. So we know that it is the ST segment elevation, but here we are going to understand why is this ST segment elevated and can we identify the wall of injury using the ECG leads. So first, coming to the ST-EMI, that is the ST segment elevated myocardial infarction. So why is it so? The ST segment elevation is happening. To understand it, first we have to understand what is this current of injury. So this is because of the current of injury. So let's take for example, there is a myocardium like this and there is a part which is going for an infarction. Due to the compromise of the blood supply, there is a particular area which is getting infarcted or ischemia is happening. So this injured area, what it becomes is, it becomes depolarized. So it becomes depolarized. Depolarized means we know that it is going to become positive charges. And what it is going to do is, it is going to throw away the negative charges away from the area of injury. So the negativity is moving outside. So which part in the ECG indicates depolarization? We know that the ventricular muscle depolarization is indicated by the QRS complex. So because of this excessive depolarization, we are going to observe some changes inside the QRS complex. Let's see what happens. So now we are going to compare the normal one with the myocardial infarction. So what happens in this patient is, in this patient there is excessive positivity which is getting emitted. So in a normal patient we have the PQRS complex and the T wave. Here what is happening? We are having excessive depolarization. So which in turn will produce a lot of excessive action potential or a prolonged action potential. Both of it will be introduced. Suppose for example, now additional action potentials are being produced and sometimes they are prolonged for a longer duration also, especially the plateau is getting prolonged. So what will happen to the QRS complex? Instead of the R wave, so Q wave is there, instead of the R wave coming down like this, what is happening? Now more positivity is happening. So it will not keep on coming down. Instead of that, it is going to try to stay relatively more positive. And by the time the T wave also merges with it. So why this elevation has happened? Here ideally it has to come down, but right now we have more positivity. So what is happening? It is trying to stay in the positive level. And finally the T wave was also occurred and merged with it. Why is this abnormal positivity is there? Because of the current of injury. So what is the finding? We see it in the ECG. We see the ST segment elevation. So the ST segment looks elevated in the ECG. So ideally it would have dropped down, but now positivity is available. Some other phenomena is also contributing to the ST segment elevation. So this is phenomena number 1. And in some of the group of patients, it is not the depolarization which is causing the effect. It is the negative charges which is being emitted, they cause the effect. How is it so? Let's try to understand. This lead on to TP depression, which also resembles ST elevation. I will explain you how. Now here the surrounding area, this is the positive area, and the surrounding area, what has happened? It has become negative. Now the repolarization will start after the depolarization. The repolarization will cause the T wave, and after the T wave, what is happening? There will be a TP segment. I told you there is a segment which happens after the T wave, that is called as TP segment. Why is this TP segment happen? When all the ventricular muscle is becoming repolarized. It's not depolarized. When all the ventricular muscle is becoming repolarized, what will happen? They will get a flat line, which is the TP segment. But right now what has happened? In this surrounding tissue, we are having excessive negativity. So we are having excessive negativity in the surrounding tissue. So what will happen to this TP segment? The TP segment was happening because of the complete negative charges. Now there is excessive negativity. So slightly the TP segment will come down. So let's try to understand what happens. Suppose this is the normal one. What happens in an MI patient is the P wave, there will be no changes. The QRS complex also has come down. Then the T wave. Then after the T wave, now what has happened? The TP segment has to come when there is negativity. But right now, this TP segment comes a little lower down. Why the baseline is shifting lower? Because there is availability of more negativity. So this TP segment, I am not doing any change to the diagram. I am just putting the TP segment down. And finally, the wave will be coming like this. And next P wave will come. Then after that, the QRS complex will come and the next T wave will come. So what we have done is we have just lowered down the TP segment. Why is this lowering down happen? Because of the excessive negative charge in the surrounding area, which is lowering down. If you look at this closely, again this image also is giving a ST segment elevation. So ideally a TP segment depression, when you look at the ECG also, as you can see here, QRST. So this also looks like an ST segment elevation. That is why both the groups, whether it is due to the prolonged action potential causing a proper ST segment elevation or a TP depression, both of it will finally look like an ST segment elevation in an ECG. So I guess most of you would not have understood this while you are reading it, whether it is due to TP depression or due to a proper ST elevation. Both of them we will look in the ECG and find the ST segment elevation. So if a patient comes to you with complaints of cardiac pain and if you are suspecting a myocardial infarction, you are going to take an ECG and the acute phase will show us the ST segment elevation. I am mentioning it here, it is the acute phase. On a later date or after a few hours, this change might disappear also. That is why it is immediately required and we have to try to take the investigation immediately. So that is why acute phase is important. Now, can we identify with the help of different leads like which wall of the heart is affected? Of course, yes, because now we have too many cameras which are taking pictures at too many different angles. Depending on the positioning of the camera or the lead, that lead will capture the ST segment changes. So for example, the heart is like this. And surrounding the heart, we have various leads. This diagram we have already seen. This is lead 1, this is lead 2, this is lead 3, and this is AVF, AVL, and AVR, augmented leads. And the chest leads V1 to V6, we have it. Now looking at this diagram, tell me which cameras are placed in the lower region or the inferior regions of the heart. As you can see from this diagram, 3, AVF and 2. So these three cameras, lead 2, 3 and AVF, is taking the picture of the heart from the lower direction. So obviously in an inferior wall MI, all these three leads or 2 out of 3 in these three leads can show the ST segment elevation. So if it is an inferior wall MI, which cameras will capture? The lead 2, the lead 3 and AVF, all of them will capture. And coming to the lateral wall, just see the diagram and tell me which are present in the lateral wall. The AVL, the lead 1 as well as V5, V6. So AVL, then lead 1 as well as V5, V6. All of them will capture the lateral wall MI. Now coming to the anterior wall MI, anterior wall we have the V1, V2. V1, V2 will capture, Anteroseptal next to the anterior wall, anteroseptum is there, that is a V3, V4. Some book says this all four leads will capture the anteroseptal or the anterior wall. So that is how, depending on the direction of the ECG lead placement, and just by looking at an ECG, you can easily identify which wall of the heart is having an MI. So that's the advantage of having multiple cameras. And multiple cameras are placed so that we do not miss capturing the heart. But we do not have anything in the posterior wall. Sometimes if you suspect a posterior wall MI, then there can be additional placements of chest leads which can be done, that is V7, V8 and V9. I have told this additional leads in the lead placements itself. So that can be done for the posterior wall MI. Now what are the other changes in MI? Now one thing is very classically we understood that there is an XT segment elevation. Other than that, there can be an XT segment depression in the opposite leads. Suppose for example, the AVF is showing a ST segment elevation. The AVL, the opposite lead, can show the ST segment depression. So that is one thing. And there could be an hyperacute tall T waves. The T waves can also become tall in the leads where the ST segment elevation is happening. So this is the second change. Even in hyperkalemia, you can get a tall tented T wave. In a similar way, tall T waves can be present in case of an MI also. Then appearance of Q wave. Some of the leads generally do not have Q waves, but if they start appearing in the leads in which they were previously absent, that could be an indication of an MI. So these are the other changes. It is not only the ST segment changes, but other than this, other changes also can be there. So all these changes, that is the ST segment elevation, of course, that is the primary change, along with other changes, will happen in case of an acute phase. In the next phase, what will happen, which is also called as evolving phase, as and when, suppose the patient had a chest pain and he has not reported to you immediately. He is coming after 1 day. Fortunately, he has survived the attack and he is coming to you after a day or two. In that, what will happen? The T wave inversions will happen. The T wave which was tall, now it will become inverted. And next, what will happen? There in the resolving phase, there is regression of the ST changes. The ST segment which was elevated, now they will become flat and sometimes even normal also. And if you look at the chest leads, there will be a, generally what happens in a normal person, progression of R wave. I already taught you, we have to look for the progression of R wave. In an MI person, this also could be lost. So these are the changes. As and when the MI evolves, these changes can be observed. So let's see with the help of a diagram. This is an inferior wall MI. So the cameras inferiorly, they will capture it. What are the cameras inferiorly placed? That is lead 2. You can see the ST segment elevation, lead 3. Then AVF. All these are showing the ST segment elevation. And in the opposite lead, you can see there is an ST segment depression. AVL, it has a depression. And as and when the MI progresses, what has happened? This is A is the acute phase and it is progressing to B and C. In the B, we can see in the same lead where the ECG ST segment was shown, now there is an inversion of a T wave. Inversion of T wave has happened. And finally, you can see here it has become a flat line also. Now it is not elevated. It has become a flat line. So this is called as a resolving phase. So B is nothing but our evolving phase. And C group of diagrams is nothing but a resolving phase. So all these changes can be seen. So classically, as you can see, lead 2, lead 3 and AVF is showing the changes. So it is obviously an inferior wall MI. So this is all about MI, which is the ST segmented elevated MI. Whenever you look at the non-ST segmented elevation, what happens in this is there is an ST segment depression. There is an ST segment depression which can happen. And generally this XT segment depression happens in a non-STEMI because only the innermost region, that is the subendocardial region of the musculature or the myocardium is affected, leading on to the ST depression. So here they have compared the subendocardial injury with the transmural injury. Most of the times it is the transmural injury or the entire myocardium is getting affected, leading on to an ST segment elevation. Whereas if it is just the subendocardial or a very minimal part is involved, you might find an ST segment depression also. which is called as non-ST segment elevated MI. Why it is non-ST segment elevated? Because ST segment elevation is expected in an MI, but that is not happening. So these are the changes that will happen in a non-ST segment elevated MI. So if you are getting a case of MI, first thing is the ST segment elevation has to be checked. But sometimes if the ST segment elevation is not there, but still the patient is giving a classical history, you cannot eliminate MI just because it is not shown in the ECG. Sometimes we have to go on to the next step of investigation where you might pick up the ST segment elevation is, that is, you can perform the patient stress test, which is also called as TMT, treadmill test can be performed, and there you might see some findings. In a patient of angina also, whenever they are doing a stress test, what will happen? These hidden ST segment elevations can be observed. ST segment elevation is one good clinical sign, but you cannot eliminate the MI completely if it is absent. So this is one thing you have to remember it, and you have to have it in your mind while you are practicing. So I hope it's clear. Thank you for watching the video. We'll see you in the next video. If you have any doubts, kindly put it in the comment section. I'll be happy to make a video on it. Thank you for watching. Stay tuned for more such videos.